Hey everyone, welcome back to the channel where medicine meets clarity. Today we're diving into one of rheumatology's most classic acronyms, CREST syndrome. What does it mean, what causes it, and how do we treat it? Stick around, because we're about to make systemic sclerosis a little more understandable. CREST syndrome is the limited cutaneous form of systemic sclerosis. It's a chronic autoimmune condition that affects the skin, blood vessels, and internal organs. The acronym CREST stands for 5 hallmark features. C is for calcinosis, deposits of calcium under the skin. R is for Raynaud's phenomenon, color changes in the fingers triggered by cold. E is for esophageal dysmotility, leading to reflux or trouble swallowing. S is for Sclerodactyly, tight, shiny, thickened skin over the fingers. T is for Telangiectasia, small, dilated blood vessels on the skin or mucosa. So how does this happen? CREST syndrome results from 3 overlapping processes: immune system dysfunction, vascular damage, and excessive fibrosis. The immune system produces autoantibodies, especially anti-centromere antibodies. Small blood vessels become damaged, reducing circulation to the extremities. Fibroblasts go into overdrive, laying down excess collagen that hardens the tissues. Who's at risk? Primarily women between 30 and 60. Genetic factors like certain HLA types play a role, and exposure to environmental triggers like silica or organic solvents can increase the risk. In many cases, Raynaud's phenomenon is the first sign, fingers turning white, blue, then red. Esophageal symptoms may follow, like acid reflux or difficulty swallowing. Patients can also develop finger stiffness, telangiectasias, or painful calcium deposits. Diagnosis starts with clinical suspicion. Blood tests almost always show a positive ANA. Anti-centromere antibodies are strongly associated with CREST. Echocardiography helps detect pulmonary hypertension. Barium swallow or esophageal manometry assesses motility issues. And nail fold capillaroscopy reveals microvascular damage. Treatment is symptom-based. There's no cure, but management helps. Calcinosis may require surgical removal or minocycline. Raynaud's responds to calcium channel blockers and warmth. Esophageal symptoms improve with proton pump inhibitors. Skin tightening can be slowed with immunosuppressants like methotrexate or mycophenolate. And lasers may help reduce visible telangiectasias. The biggest complications? Pulmonary hypertension and interstitial lung disease. These require close monitoring with annual echocardiograms and pulmonary function tests. If problems arise, targeted therapies like bosentan or sildenafil are used. The good news is that CREST syndrome often has a more favorable prognosis than diffuse systemic sclerosis. With regular follow-up and personalized treatment, many patients live full, active lives. Let's recap. CREST stands for 5 distinct features: calcinosis, Raynaud's, esophageal dysmotility, Sclerodactyly, and telangiectasia. It's an autoimmune process involving blood vessels and fibrosis. Diagnosis relies on clinical features, antibodies, and imaging. Treatment is symptom-specific and proactive. Pulmonary complications are the most important to monitor. And overall, the outlook is hopeful with proper care. Thanks for tuning in. If you learned something new about CREST syndrome, give this video a thumbs up, subscribe, and drop your next topic in the comments. Stay curious, stay compassionate, and keep learning.